Good evening, and thank you for attending AACP's webinar with Brian Tuckey presenting Fascial Counterstrain and Craniofacial Pain. I'm Shaylin, the Association Manager for the AACP, and I'll be the host of the webinar tonight. This webinar is approximately 50 minutes, followed by a 10-minute Q&A session. Please enter any questions you have in the bottom of the Zoom screen, and we will address them at the end of the presentation. The AACP has no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 10 to 14 business days, and AACP members attending live will receive their CE certificate of attendance within 30 days of the webinar air date. AACP's next complimentary webinar will be December 13th with Scott Parker presenting Sleep, Snoring, and Airway Issues, Why It Matters. Our moderator tonight is Dr. Charles Fursley. Dr. Fursley graduated from the University of North Carolina at Chapel Hill with a Doctor of Dental Surgery degree in 1997. He worked in a Medicaid office for a year, followed by 2 other associateships before starting his own practice that is equipped with some of the latest and greatest dental technologies. Dr. Fursley has dedicated time to upgrading his knowledge in various areas of dentistry and has taken more than 100 hours of continuing education every year for the past 19 years. Dr. Fursley is a member of the Academy of General Dentistry, the American Academy of Pain Management, the American Academy of Craniofacial Pain, the American Academy of Orofacial Pain, and the Academy of Dental Sleep Medicine. This August, he was elected to AACP's Board of Directors and took on the role of AACP's Education Chair at the end of September.
Thank you, Shane. Tonight it is my honor to present to you Dr. Tuckey, who is a board-certified orthopedic specialist who graduated magna cum laude from the University of Maryland School of Physical Therapy in 1990. He's the owner of Tuckey & Associates Physical Therapy in Frederick, Maryland, and he specializes in the treatment of failed chronic cases. In 1992, Dr. Tuckey began training at the Jones Institute under the guidance of the famous osteopathic physician, Dr. Lawrence Jones, DO, who was the originator of strain and counterstrain technique. Eventually, Dr. Tuckey became one of 4 physical therapists in the United States to be certified by Dr. Jones to teach strain and counterstrain. In the late 90s, following the death of Dr. Jones, Dr. Tuckey took over the reins of counterstrain innovation and expanded the counterstrain curriculum from approximately 200 to over 1,200 anatomically specific treatments. Today's Dr. Tuckey's modern version of counterstrain is called Fascial Counterstrain, and it has the unique ability to identify and correct dysfunctions in all bodily systems, including the vascular, visceral, nervous, and musculoskeletal systems. His multi-system approach is unique in the world of manipulation, giving it unparalleled diagnostic and curative capacity. Fascial Counterstrain is a 13-course curriculum. It's being taught by Dr. Tuckey through a rapidly expanding audience of domestic and international medical professionals. I've had the privilege to be one of his students in many of his courses, and I find his system to be fascinating and of great interest to members of the AACP. So tonight, Dr. Tuckey, we look forward to hearing more about fascial counterstrain.
All right, thank you, Dr. Fursley. As Dr. Fursley stated, what fascial counterstrain is basically a modern form of manipulation. It is a technique that is something that can be applied to all systems of the body, all parts of the musculoskeletal system, and all regions of the body. So we can treat the myofascia, the vasculature and neurology inside of bone, ligaments, cartilage, the entire vascular system, including arteries, veins, and the lymphatic system itself, the entire nervous system between somatics, autonomics, and cranial nerves, including, of course, the trigeminal, and all the viscera and mesentery. What many of you would not be aware of are that there really are 2 different types of manipulation. One is, of course, direct techniques, which is what the vast majority of practitioners are doing. and basically you find a restriction and you basically try and force through it. So it's kind of what this little far side video is showing here. Whereas indirect techniques really diagnose where the nociception, where the pain is being driven from, and we decompress the nociceptors, both physically and chemically, to alleviate the inflammation, which we'll talk about, that really drives chronic dysfunction. So basically, it is something that is in the opposite direction. It's painless compared to other techniques where there, often, of course, is pain produced. And the carryover, because it really diagnoses the source of the chronic inflammation, is really unparalleled. So it's basically backwards from virtually all forms of manipulation. Indirect techniques are not widely utilized because the learning curve is much, much longer, but they're definitely taking over in the world of manipulation. So again, you heard a little bit of my background, but basically Dr. Larry Jones, who's pictured here, started the approach of counterstrain, back in the 1960s. Really, he started developing it, started teaching it in the late 80s and into the 90s. I met him in 1992, eventually became one of only 4 instructors that taught for him his version. He had identified about 200 diagnostic tender points and how to release them, and would describe all the signs and symptoms of those dysfunctions and what would resolve. But at that time, to be honest, we really didn't understand exactly what we were doing, what tissues we were impacting, and it did limit the effectiveness because it was really a new technique at that time. I took the reins of development around 1998 or 99, and really expanded Dr. Jones's strain and counterstrain original 200 points to, again, upwards of 1,200 points today. This slide, I think, says 800 because it's an old slide. But it's a expanding curriculum. I also then really correlated each one of these surface tender points to what it is representing through convergence deeper in the body. So for example, the maxillary branch of the trigeminal nerve has a surface tender point. The mandibular branch has one. The retrodiscal pad has one. So there are surface tender points through the science of convergence that relate to these deeper inflamed tissues. I also developed, multiple different assessments that we utilize that allows us to rapidly identify where these points are, so we don't have to actually poke all 1,200 of these tender points. So there's an assessment to find that area of inflammation, and then we apply the treatments, which are, again, anatomically based. So really talking about the technique is kind of difficult, as you would imagine. So let's watch a video here real quickly of an indirect technique in action so you can get an idea of how counterstrain works. This is a live treatment that is taking place in one of my nerve classes. This gentleman here had about a 10-year history of limited external rotation in the shoulder. It was an extremely painful limitation. You'll see him try and bat my hand away when I try and stretch him. He had it treated, he said later, over 40 different sessions of treatments without any effect, but he did not have the indirect technique. I diagnosed him as having an inflamed upper subscapular nerve. I decompress that sheath, drain the inflammation, and then you'll see the protective subscapularis muscle spasm disappear and the range of motion come back. About 3/4 of the way through the video, that particular dysfunction clears, and I run into a myofascial problem related to a muscle chain, and then I cleared that out. But you'll see that it is a painless technique, and you can see the results here real quickly. Range of motion wise. Okay. So this is a neural subscapularis problem, and we'll come in here to the belly of the subscapularis, and it's popping out right there. Okay, you got his expression there, and there's a resistance right there. Okay, one more time, and drop the arm, and it's hitting resistance right here. Okay, so we're going to come in, and we will go into the upper aspect of the scapula, and we're going to glide the upper subscapular nerve back where it belongs. We're going to leave this arm in a little bit of slack so we don't irritate him. Right back there. Now it's a nice relaxation occurring, and we're going to finish the release. Are you in the same place where you were before when we did the range of motion? Come back. Okay, so yeah, come back over here, and when we're done here, how's your feel good there? Yeah, it's feeling good. Okay, all right. So that's finishing the pulse in this area. So we'll come back, And we can go much, much deeper in that one release, and I want you to drop. Okay.
Now we got it.
Yeah, now what jumped in next though is this guy right here, which is pec. Okay, feel that? Okay. So that's a pectoral fascia. You can stay there, okay? So this went from wherever we were already here now, and now we'll come here to the fourth rib. This is pec fascia. Right there, and it goes all the way down the arm. This is a future class, by the way. So we're gonna come over here, and we're gonna come in and try and rotate. This is one of the muscle chains of the pectoralis, which goes all the way down into the carpal tunnel. Okay. So I'm monitoring this all the way into the scaphoid area, and it's pec major, projects to the fourth rib, axillary line, all the way down to the carpal tunnel, and shows up on the scaphoid. Okay, there I'm getting a good pulse in here. Finished up. Very good. Drop down, and go ahead and drop.
And then the resistance is.
The resistance is gone, right. So it's no longer popping out. I got the same pressure in there, and he's to here now. Right, okay, so as you can see, again, that's not what you typically would see in a physical therapy office, where they would be forcing the patient into external rotation. There would be pain, and then sometimes people aren't able to tolerate the treatments, as you would imagine. The carryover is also excellent. I saw that gentleman in multiple classes, and that particular treatment never had to be repeated. So then the next question then is, what exactly did we do there? Well, Counterstrain, essentially what it does is let me get this line up here. Counterstrain identifies again and releases the source of the inflammation, and the muscle guarding is secondary to those nociceptors that are triggering pain responses back into the spinal cord. So basically, once you identify that inflammation, treat it with the decompression like you saw, you'll see muscle guarding reflexes and even somatosympathetic reflexes will normalize, and you'll get relaxation of the guarding of the muscle, which you saw in the subscapularis, which was guarding the nerve. And then you also can see changes in blood flow, because sympathetic nerve activation also resolves when you turn down the nociception. This is one of the slides from our foundations class. It is, I'm trying to give you guys really what is almost a 3-hour lecture here in a few minutes and show you some techniques. And I'll also later, just to get ahead of things a little bit, there is a published article on this entire paradigm of tender point formation, which was published in Frontiers of Musculoskeletal Pain in 2021, and it is a 145 citation paper to describe exactly how all this works, which you guys can download. But anyway, what happens is, and this is an example where the inflammation or the tender point would be associated with the anchoring ligaments of the liver, like the triangular ligament of the liver. That nociceptive barrage would go in to the cord and go into the ventral horn, driving muscle guarding reflexes. But that same nociceptive barrage, driven by that inflammation, also goes into the intermedial lateral column and drives sympathetic responses called sympathetic nerve activation. And this causes vasoconstriction at that same segment. So what you get from one area of trapped inflammation and activated pain receptors is not only chronic pain, you get muscle guarding, loss of range of motion, joint restriction, and you can get changes in the vascular flow. So you get chronic edema, you of course can see trophic changes, degeneration over time, all driven through one nociceptive barrage. And the technique simply identifies these areas in the body where this chronic inflammation is trapped and alleviates it. So let's look at some of this sympathetic drive type change in action. So again, you just saw a change in the muscle guarding reflex with that range of motion, but now let's look again at what Counterstrain can do for vascular dysfunction. So this particular lady, she fractured her humeral neck. It was a mild fracture on December 24th in 2010. This particular picture was taken by her husband, and this was 9 days after the fracture. She went to the ER. They just gave her a sling and swath and some non-steroidals, but she was in severe pain. So she ended up going into one of my practitioners, and he sent me this picture and said, would you treat her? And I asked if she had a Doppler. He said yes. I said yes, go ahead. And so he went ahead and utilized basically venous and lymphatic treatment techniques and some other techniques to her right lymphatic watershed, which you can see is extremely clogged. And anyone who's trained in lymphatics, this is a very classic right upper lymphatic watershed. And he was able to clear out all the tender points down through the elbow and ran out of time right about here. Okay. So the next picture is 48 hours, about 36 hours actually, after this treatment, and realize again, this was what the body was able to do in a state of vasospasm in the first 9 days. And then you get to see what happens in the next 2 days or so after treatment. 2 days later, and there she is. So obviously a dramatic change in the edema, and obviously all of the larger, molecules, of tissue damage, etc. But what's most remarkable is you'll see he ran out of time right here, and the distal venous structures like the radial and ulnar veins were not treated, and that part did not resolve. So you can see the, kind of the power of the technique, which was not intentional because he just ran out of time. Here's an arterial case. Once again, same philosophy of identifying inflammation related to the arterial pathways and fixing that sympathetic activation that's ongoing. So this particular gentleman was a patient of mine. He was climbing down a ladder in 2013, ended up getting a compound fib fracture in his ankle because his foot slipped through the ladder and he fell down and just basically snapped his ankle right there. He also tore 2 of the 3 main arteries in the calf. The tibialis posterior fibular arteries were torn. Took the shock trauma flight to Maryland shock trauma. It had an ORIF, 8 screws and 2 plates performed. Plus, after that, they saw that his ankle blood pressure was near 0. So they took him back in and placed a femoral stent to try and get more blood to that ankle so that it would be viable. And after all of that, the vascular repair, the stent, etc., they could only get his ankle blood pressure reading to be 50, where that distal ankle blood pressure reading should typically be about 105, 106, 107. The surgeons, both the vascular and the orthopedic, told him that his prognosis was not very good. The vascular surgeon said that he should, strongly consider amputation because his ankle was not viable. Now, he luckily knew a massage therapist that knew about our clinic and knew me and talked him into discharging himself and go up for a trial treatment of counterstrain. I treated him for basically 2 weeks, about 2 or 3 sessions, and then sent him back. At that 2-week follow-up, the physician was able to palpate a dorsalis pedis pulse for the first time and said, I don't know what you're doing, but whatever it is, keep it up because amputation is off the table. And then at the 6-week follow-up, he had his full workup and found that his blood pressure in the ankle was normal. And this was the shot at 6 weeks. So again, this is a chronic state of sympathetic activation, arterial vasospasm. And then this is obviously, where that had been alleviated using the technique. And then one more quick little show and tell case study here where we have some before and after evidence more than just subjective. This was a patient who had chronic osteomyelitis and bone marrow edema. She had a fracture and an infection in her toe and basically, had 3 years of chronic distal phalanx pain in her big toe. She was a trail runner and she was basically having pain just walking. Had several different medical interventions unsuccessfully. And 2016 MRI talks about this hyperintensive T2 signal all throughout the distal phalanx. Again, she was treated with podiatry, IVs, and several different things that did not resolve her problem. 2019, you can still see there's a significant amount of edema in her distal toe, even spreading, into the fat pads in between the toes and to the second digit. And so she then said to me, she actually was a massage therapist and took one of my classes, as did Dr. Fursley. And she said that they were now recommending that if she wants to run, that they would also amputate her toe. So I did a quick assessment on her, and I said that you have bone dysfunction, which is the blood supply, the neurovascular structures, nutrient vessels inside the bone. And I said, let's try a session or 2 before you go doing that. And after the first treatment, she, it went very well, and she had an 85 to 90% reduction in pain all her color externally normalized, and she was able to actually go trail running within 74 hours. And then I wanted to see if that subjective and functional improvement would also show up. So I actually personally paid for an MRI, which the treatment was done in October, and we got the MRI a little bit later in November of 2019. And then there's the post-treatment, showing the bone marrow edema had resolved. And then the same doctor read it and said there, basically there's no evidence of that continuing periosteal reaction, okay, and osteomyelitis. All right, so when I talk about treatment of bone, you'll understand we're really treating the neurovascular structures that go into the bone, which of course creates nociception. The bone becomes painful, it's edematous. You can see trophic changes, demineralization, avascular necrosis, all types of things. All right, so now let's look at a TMJ example. So this particular patient is being interviewed by a Dr. Rogers, who is a TMJ specialist here in Frederick, Maryland. He's also my personal dentist, and he's had the treatment himself done many times. And this guy came into his office and was in visible distress with his TMD. And you can see the pain in his face, how little he's moving his jaw. He called me up and said, Brian, can you sometime this week, squeeze this gentleman in? I don't want to do any work on him until you free things up. And I just said, I don't have any openings, so I'll just bring him over tonight. So I treated him later that night. So the second half of the video was the same day after having his first session of fascial counterstrain, really multi-system. I treated many things. So let's take a look at him.
I came in here today for TMJ problems. I've been having them intensely for about the past 5 years. At about the end of high school, in 2009, I started getting some jaw locking when I would open my jaw all the way. And I would just correct that by knocking my jaw back into place. But over time, the pain got worse and worse. And over the past 3 years especially, I've just been having incredible pain and tension, especially in this side of my face, radiating kind of from the ear area in the back of the jaw. It'll move up and around my head. Over time, the tension's gotten worse and worse. The functionality of my jaw has gotten worse and worse. I've been hearing sounds in my ears, all sorts of strange, muscle spasms in my jaw. Been heavily medicating with, anti-inflammatories for the past few years, but at this point, nothing really touches the pain. In the past year, it got really bad to the point where I've just been really restricting my jaw motion at all. But in the past month, it's gotten to the point where I'm having problems eating and stuff. So,
Go ahead and just describe what your experience was. What you think about the first treatment there?
First treatment probably only took about half an hour, and after 4 years of constant pain, I feel significant release of both tension and pain throughout my jaw and the back of my neck. In fact, this is the first time I haven't had serious pain in my ear in a long time, and I can't believe it happened that quickly, actually.
All right, great. So we'll go ahead and just take a look at your motion real quick. Just open up there for us. And okay, how's that feel?
Wow. I mean, I can feel a little bit of tension there, but compared to how it's been, it's incredible.
Okay, and side to side for us, how's that feel?
Side to side of the jaw.
Okay.
Oh wow. Not only is there was no pain doing it, and I didn't hear the loud grinding sounds that I got so used to. It's already leagues better.
Okay, all right, great, thank you.
All right, so again, that was really a multi-system. I did some, muscles of mastication. I did some of the trigeminal pathway. I did some of the retrodiscal pad, cartilaginous, and bone treatment as well. All right, so let's talk a little bit more about the physiology behind the technique. And, I don't like to go into that right away until you, have a little bit of clinical context. So the first question I typically get is, all right, if this releases inflammation, where is it trapped? Okay. And the answer is that the inflammation is actually trapped in the microvascular system. And that whole idea of there being this microvascular system or interstitium is relatively, new science. This particular study by Benias in 2018 was one of the first American studies published to talk about the microvascular system, and they utilized CLE, confocal laser endomicroscopy, to identify these tiny little channels and bundles of collagen that were filled with interstitial fluid. They termed them basically pre-lymphatic channels that eventually dump into the regional lymphatic vessels. They were identified really everywhere, just like the tender points that we treat in Counterstrain are found virtually everywhere. The entire GI tract, urinary bladder, the subcutaneous tissues like the superficial fascia, peribronchial, perivascular along the vascular sheath, neural sheath, and all musculoskeletal fascia, it said in the article itself. So basically, it's very, very ubiquitous, just like fascia itself, and it's this flowing, clear fluid. I always describe it to the patients. It is the blister fluid. It is the lymphatic fluid. It is not blood. So when you get inflammation in this area, you can take medications and many things, but it would have to then leach into the interstitial space, then get into this area of stasis, which we'll talk about, to try and have any effect. And that's why medications or non-targeted therapies can be ineffective many times. Now, is there any other evidence that this inflammation in this interstitial fluid exists? Well, yes, it does. It's actually been found years ago. Actually, one of the guys on my paper, one of the famous physicians, Dr. Jay Shah from NIH, I talked him into sampling the interstitial fluid for inflammation of active trigger points way back in 2007. He and his team made a microdialysis needle, inserted it into active trigger points, compared it to the other side, interstitial fluid, and found 23 different elevated cytokines that were elevated in concentration, and even catecholamines like norepinephrine were also found in there, which is related to the vasoconstriction in trigger points. And again, this sampling, studies have been done to repeat that, but then they've also recently done diagnostic ultrasound and found constricted vascular bed around trigger points. So the bottom line is that this inflammation has also been shown in sampling studies to be present in symptomatic individuals. So Counterstrain, what it does essentially is we create a negative pressure or a vacuum in the area of the identified stasis, or what relates to the tender point. So if you look at the lymphatic system, and again, there's quite a bit of discussion we have to do in that world. There are anchoring filaments in the valves of the lymphatic collecting vessels, and when you decompress the tissue, those elastic filaments open up, and that fluid drains in. We hold it open, and when you stretch lymphatic vessels, they actually have a lymphangion that pumps, and it increases its pump rate and basically pumps the fluid right out. So we decompress, hold, and you actually feel this wave of subtle pulsation in your finger. You feel it more readily as you're trained, and you just wait until that finishes. And then you've drained all that interstitial edema, which is causing the nociceptors to fire ongoing, which is the root of the problem. So all the muscle guarding, all the vasoconstriction, all those things are spinal cord reflexes related to this nociceptive barrage caused by this area of inflammation. So the hard thing to do then, of course, is find it. You have to identify it, and then you have to drain it. And so the entire curriculum basically teaches you how to find the areas of inflammation in each system and each tissue. So basically, again, the concept of interstitial inflammatory stasis causing chronic pain, being at the root of chronic peripheral pain, is now a published paradigm. This is the paper I was talking about, published in Frontiers of Musculoskeletal Pain in August of 2021. Dr. Jay Shah from NIH and Dr. John Serberly, who's a real well-published chronic pain doctor from Canada, and then two other physicians that I know were all on the paper, and it did very well. It is actually, if you look up on Frontiers of Musculoskeletal Pain, most viewed articles, most downloaded article all time, it comes up #1. And so the theory is actually the current and really only peripheral pain theory that hasn't been disproven. It is the most up-to-date theory of peripheral pain. All right. And again, it is open access. You can pull that up and you can read that. It's a whole flow chart that describes how the stasis occurs. But let's go through real quickly a little bit about the stasis and just a summary. So if you read the article, it'll be easier for you to grasp it, reading it rather quickly. So basically what, causes the entire process is the exposure to pro-inflammatory cytokines. And of course, you can get cytokines produced in tissues following traumas of any kind, including, of course, surgeries, immune responses. That's where your long haul post-COVID comes in, for example, post-Lyme disease, post-sepsis, all these chronic pain situations, post-infection. Hypoxia can create inflammation, and so that's all your postural strain syndromes, and even chronic stress. Chronic stress throws off your HPA axis. You end up, getting adrenal fatigue, if you want to call it that, produce less cortisol, and end up being chronically inflamed, not to mention all the sympathetic activation. So there are multiple ways that you can produce pro-inflammatory cytokines in the tissues. Now, of the 33 known pro-inflammatory cytokines, these three, interleukin 1b, interleukin 6, and TNF-alpha, are most associated with chronic pain states. So that was kind of the clue. So I really looked into the science behind these particular cytokines to see what they were doing in the body. And it turns out one of the key things that they do is they make regional tissues, including macrophages and fibroblasts, produce another cytokine called TGF-beta1, transforming growth factor beta-1. And based on some 2019 research that was done, TGF-beta1 causes, if you just drip it on to a ligament, for example, that ligament will contract. It makes the intrinsic myofibroblasts in soft tissues contract. So it makes fascia contract. So if you get enough cytokine exposure, you'll contract that local tissue and you'll block the drainage of those pre-lymphatic channels into the lymphatics. Okay, so that's the crux of it. Enough cytokines in that area, you can block all the drainage and you'll get an area of stasis. Okay, repeated traumas will block more in an area. Severe traumas like fractures or surgeries are very likely to cause some of this stasis. Now, in the research article, it'll talk about when you get this trapping of these particular cytokines, what else happens? Well, first of all, those cytokines are all known to cause pain. They'll chemically stimulate nociceptors. So there's your chronic pain. When nociceptors fire via that spinal cord loop that we talked about, you then get sympathetic nerve activation, which creates vasospasm, a decrease in perfusion. You'll get artery and vasoconstriction of the veins. So decreased blood flow in, decreased drainage out, poor health of the tissue. Those same nociceptors also go into the skeletal muscle, alpha motor neuron area, ventral horn, and cause muscle guarding reflexes. There's your range of motion loss. So a key thing that you probably have already surmised is that when you see a surface muscle contraction, okay, whether it's in the muscles of mastication, temporalis, pterygoids, or in the body elsewhere, the paradigm is that that muscle is the source of the problem. But in reality, the muscle guarding reflex guards all inflamed structures. So you need to understand, is that muscle guarding itself? So myofascia being guarded by muscle, or is it the muscle guarding another structure, like an inflamed disc or that suprascapular nerve that you saw, or the sciatic nerve? So this whole paradigm, basically looks at the muscle guarding reflex as usually a secondary thing and finds what it is, in fact, triggering that reflex, which is the inflamed tissue. And that tissue can be any tissue with nociceptors. And then one other thing that's in the paper that was, very fascinating research is that it turns out that when you get these three cytokines in an area, it turns off the lymphatic pump mechanism for about 48 hours. And that increases the chances of stasis even more. And you'd probably say, why is the body doing that? Well, it turns out that those three cytokines are very commonly produced with infection. So the body assumes that when there's a major trauma or there's an infection, it shuts down the lymphatic pump and wants to go in attack mode and not spread that infection around. So those cytokines, by knocking out perfusion and knocking out the lymphatic pump and contracting the fascia, can create and often does create areas of stasis in the body. Okay. Again, anything beyond that question, all your answers were in that article. And again, this is probably the best I can do saying it quickly. So then as a counterstrain practitioner, we come in, and what we're trying to do is we're trying to find this. We're trying to find this area of stasis. And through the science of convergence, there's always a surface tender point, a dermal projection from all these deep inflamed tissues. If you don't know a lot about convergence, you can actually go on to the Jones Institute Facebook page, and I did an entire webinar about 3 weeks ago on convergence, describing what a tender point is through convergence. But anyway, we use the surface tender points as a correlation to the deeper inflammation. So we're going to use multiple assessments: the tender point itself, motion testing, a cranial motion test, that is something that we use to embryologically understand which tissues are inflamed in the body. There's our tender points, and then another couple osteopathic tricks like touch inhibition. So we have multiple assessments that we use rapidly to find the key areas of interstitial stasis, and then we apply the technique. Okay, and then you see this results here, these change. So we'll get that lymphatic pump to kick back in, the muscle guarding goes away, the vasospasm resolved, and the pain drops down. And then we reassess for the next worst area of interstitial inflammatory stasis. This is the flow chart from the paper, showing you that's a bit more complex than what I just described, but this goes through this whole positive feedback loop created by those cytokines. There's a summary of the entire process in the paper, and even a suggested treatment, which was counterstrain for the problem. And what the paper really is, it's not a paper about counterstrain. It's a paper about, what creates tender points. What is a tender point? The research did not really elucidate that. No one was able to describe how tender points are created and maintained in the body. Okay, and that's really what the paper did. Okay, so before we run out of time here, let's talk a little bit about some applications that we could apply to the field of craniofacial pain or dentistry. So obviously TMD, trigeminal neuralgia, would be two examples. I actually saw a trigeminal neuralgia patient as my last patient today. So here is a treatment and tender point associated with the maxillary branch of the trigeminal nerve. It has a tender point on the posterior aspect of the superficial masseter, and a tender point just adjacent to the nasal aperture on that upper part of the maxilla. And then I basically drive the maxilla inferior and contralateral on the opposite side, which drives it superior, and ipsilateral on the involved side. And then you can monitor one, or as I'm doing here, both tender points. And this nerve, when it's shortened appropriately, the tender point disappears, the muscle relaxes, and then we hold it for, again, 45 seconds until that dissipates. The releases are one and done. When you release a tender point, if you diagnosed it properly, you don't have to retreat it. That particular tender point will go away because you've drained the interstitial inflammation into the lymphatic system. The lymphatic system kicks back on and maintains it. This is an example of a bone technique. This is a mandibular inflare. So that mandible, if you go to the angles of the mandible and you were to give them an assessment or a spring test, you'll often see that one is flared out or one is flared in. So again, we exaggerate that deformity and treat the vasculature and the sympathetic nerves into the basically the mandible itself, those nutrient vessels, and then the bone actually frees up. It is a really interesting thing to feel when you feel a bone go from hard to soft, and it improves its congruency. So we treat the mandible itself, we treat the mandibular fossa, the styloid process, etc. So we also treat the bone to help the congruency and the articular surfaces align properly. There's a mandibular outflare, so there I'm outflaring it to turn that particular tender point off. If we go back, there I'm pushing it in and medial for the upper tender point. Okay, and then this is a treatment of the retrodiscal pad, posterior location of the TMJ disc. That tender point is on the tympanic portion of the temporal bone, just behind the condyle, and then I'm basically driving that mandible posteriorly and superior to shorten that retrodiscal pad. Once again, using the tender point and the tension to fine tune the release. And then here's a treatment of the lateral pterygoid. This is a tender point related to the superior belly, a tender point up under there related to the inferior belly. That's really the origin of the superior and inferior belly. And then there are two tender points that are projected into the deep cervical fascia on the lateral tips of C3 and C4. You can use any of those. And, of course, the pterygoids, are a deviation away muscle. So that is the shortening, and we monitor those tender points. Again, it's a shortening technique, decompression, take the pressure off. We do not engage the barrier. How about airway? Do we have techniques that we can use for obstructive sleep apnea and airway? Yes, we do. So the fibrocartilage and cartilage itself can be treated. So we have treatment for the cricoid, thyroid, pharyngeal, laryngeal cartilages, and the deep cervical fascia, which then, of course, goes on down and ends up going into the mesopneumonium and down into the mesentery of the gut. So you get this one long fascial visceral pathway that can really choke your esophagus and your trachea, cause snoring and obstructive airway. So I'll show you, treatment of two of those. And then this is really, if you were to ask me as a counterstrain multi-system practitioner, what causes, the obstructive apnea? And the most common thing you see is actually a neurologically driven from the spinal cord level, C1, C2, and its convergence into the, the hypoglossal nerve of the styoglossus and the hyoglossus. The styloglossus and the hyoglossus tongue retractors pull back into the airway, but treating them through the myofascia does not work. You have to treat the inflammation at the spinal cord level at C1, C2, and the cranial nerve itself to the tongue, and then you can see that neurologically based muscle tone disappear. It's the only thing I've ever seen really work and hold. So this is a treatment of that pharyngeal area of the deep cervical fascia and those pharyngeal muscles. There's a tender point projected above the zygoma, and then we just shorten up that entire deep cervical fascia and some of those pharyngeal muscles. So there is the release for that upper mesentery and deep cervical fascia. And then as you get into the area of C2 to C7, those tender points project to the longus colli, and a very similar release of the deep cervical fascia will work there. Again, taking some of that esophageal, fascial tension away to help open up the airway. This is one of the neurological techniques I was describing. This is a treatment of the C. This is a C1, and there's a C2 tender point for the deep spinal veins. So we put a little stretch on the spinal vein, and you can monitor the pterygoid, or that the C2 level. You can monitor the hyoglossus, and that's the muscle that will relax with the treatment at C2. And then there's a deeper technique into the dorsal aspect of the cord, an astrocyte type inflammation release that, once again, also done at the C1 and C2 levels, where there's a rotation and side bend toward with a posterior anterior glide. And again, you can monitor several different tender points. Again, both of the tongue retractors you can monitor, and or the occipital membrane to calm that inflammation at the cord level. And again, very, very common to find that in obstructive sleep apnea. And then last but not least, we have some applications that we could, of course, use all the way into the teeth themselves. So this is a little diagram of the diagnostic tender points. Ligaments are blue, the nerve is yellow, the artery is red, and the vein is green. And if you look at an individual tooth, tender points in those locations relate to the periodontal ligaments. Of course, this would be the maxillary artery, the maxillary nerve, and then, of course, the vein to each individual tooth. There is a doctor/dentist who's gone through the curriculum, like Dr. Fursley, and she utilized these techniques for months, and then, basically wrote back to me what she saw in her dental practice these techniques could present as, and she found that the nerves, as you would imagine, could create, chronic sensitivity of a tooth. sensitive to hot and cold, again, something that was really idiopathic. She found that the treatment of the alveolar veins were, correlated often with pulpal inflammation. And if you look at the research in chronic pulpal inflammation, you'll find those exact same cytokines in my paper that are associated with in that particular condition. The periodontal ligaments, she talks about causing a subtle but profound change in occlusion, which could lead to bruxism or TMD. And then the arteries, the alveolar arteries, she found associated with gingivitis, isolated bone loss, and basically said you could even see calcification of the pulp, where there was apparently asphyxiation and even some necrosis, and said that, some of these have clear causes, but there are many idiopathic causes, and she saw a definite correlation with these structures. And then quickly here, just examining a couple of those treatments. Here are the periodontal ligaments. So we would compress that individual tooth back into the socket and monitor the diagnostic point for that ligament. So that would be a treatment of this anterior inferior ligament right there. This is a treatment of the artery. Okay, they're all found on the posterior aspect of the root of the corresponding tooth. We would rotate the head towards, shortening the entire, carotid and maxillary or mandibular artery pathway, and then you'll compress the tooth back into the socket to shorten that entire arterial pathway. It'd be compressed superior with a ipsilateral rotation for the maxillary branches, and then inferior into the socket with a ipsilateral rotation for the mandibular branches. And then the nerve tender points for each corresponding tooth project to the anterior part of the root. It's a very similar release. However, the only way to get those to turn off or release is to actually put a towel roll on the brainstem in the area of the pons, of course, where the, it's the nucleus of the trigeminal nerve, and put pressure into that area of the brainstem, into the towel roll, and then perform a very similar release of shortening that maxillary and or mandibular branch. And looking at some other, just conditions that we treat very commonly, you can see obviously there's quite a few things in the wheelhouse of this audience, including things like sleep apnea and of course all your TMD, etc. But it is a full body approach, so we treat obviously things like vertigo and POTS and even neurological diseases. So it has pretty widespread application. And so in summary here, and I know I kind of went through things pretty quickly there, but I'm trying to give you guys about 20 hours of stuff in 40 minutes. But basically, you're looking at a new paradigm in manipulation. The carryover is really something that is unparalleled. It's painless and it's multi-system. So it can be curative in many ways and as a treatment in itself for many things, but it is 100% adjunctive in many ways. So if you're about to do oral surgery on someone, treating them previously to decrease all that muscle guarding and open up the perfusion, and then go ahead and fix, say, that dislocated disc, and then clean them up after, you can just have outstanding outcomes. And I tend to work a lot with the dentists themselves. If someone has TMD, they may make an occlusal splint. I'll go ahead, or we will collectively go in and release out the inflammation and get rid of all that nociception and muscle guarding. And then the splint itself, of course, has its own effect in just keeping that jaw in neutral and stopping some of the bruxism. So really, it's something I see being adjunctive in many cases, as I said, but in many cases, it's the only treatment that really works out there for things like post-concussion syndrome and things where there really are no treatments. All right, as far as training, if you're looking to train yourself, or you're looking for a therapist to refer to, or you're thinking about finding a local therapist and saying, hey, I'd like you to consider training in this, really it's all done through the Jones Institute. So this is where the training is to train, jicounterstrain.com, Jones Institute after Dr. Jones. The first class that you would enter to get into this curriculum is called Foundations of Fascial Counterstrain. If you want to just learn more about it, you can go to counterstrain.com, which is an international website dedicated to the technique has interviews and talks a lot about, all the applications of the technique. And then there are links to the training in other countries as well. All right.
Dr. Tuckey, this was a great presentation. It touches on everything and gives everyone a good overview of what counterstrain is all about. We have a question from Dr. Gerald Murphy, who was asking, how do you equate to a purely structural issue of the TMJ, such as an anterior disc dislocation without reduction, that produces muscle dysfunction through the arthrokinetic reflex?
Yeah, that's where we get into in the classes the conversation of, are we looking at a dysfunction? Are we looking at a pathology, right? So, there are, cases where 100% it's beyond the counterstrain world. You'll need to have a surgical procedure performed. And, we typically work with dentists and work with TMJ specialists. And if they've diagnosed it as something with that severity, we would then become adjunctive versus, curative in those cases.
Awesome. So I did send a link to everyone about the article that you have published in Frontiers. So all the panelists and all the people listening in today should have a link to the article for them to read at home. And I have a question regarding how does chiropractic adjustment compare to fascia release?
So I trained in what you would call chiropractic adjustment or high velocity manipulation, many years ago. It uses a barrage of mechanoreceptor input from a manipulation to then reflexively try and stop that muscle guarding loop. The problem with it, and any chiropractor will tell you this, is that you hear the pop, you feel a relaxation reflexively, but the carryover can be quite limited. And that's because, again, it's typically articular based. It's to the joint. It is not really identifying, in my opinion, the really source of the inflammation. But let's just say that I would not tell someone not to do it, but it is a older form of manipulation that really it lacks in carryover, and I think is predominantly musculoskeletal in its bias.
Excellent. Thank you for the answer. Also, how impactful is counterstrain relative to treating patients with neuropathic pain?
Yeah, so again, a definition then of neuropathic pain, because I've gotten into this with a couple of researchers. So if you look at, nerve sheath pain, like a case of sciatica versus nerve damage. Okay, so if let's say that neuropathic, meaning, neuritis. Is that correct? Or are they asking neuropathic pain where there was nerve damage?
Spontaneous pain that ails patients, and there doesn't seem to be an organic cause to treating it.
Okay. So yeah, so what we're looking at there would be the field of nerve inflammation. So the nerve sheath itself, can trap inflammation, and that is a huge world. So again, I don't tend to get into stuff that I haven't put in the article yet, but inflammation of the nervous system, it goes all the way into the central nervous system. And I have about 4 classes that are coming out where I'm actually treating, upper motor neurons, second order and third order neurons, and the axons and the inflammation in the cord. It shows up as, neurological level tone. You cannot stretch it. And if you get rid of that inflammation, again, it breaks that muscle guarding reflex, which is very aggressive. So yes, you can apply the techniques to the nerve pathways, decompress them and drain them. It is really the only thing that works, because nerves, aggressively fight stretching, and the muscles are it's like a stroke. If you've ever seen, obviously, a stroke, you're not stretching through it. So these decompressive techniques and drainage techniques are by far superior, and really the only thing you can use.
Amazing. We have a few more questions coming through. One is asking if there are any other classic tender points to release for migraine headaches.
Oh yeah. Yes. So all the arteries, obviously of the cranium, and then the sympathetics of T1, 2, and then that causes your sympathetic drive. Of course, the trigeminal spinal, STN nucleus. So C1, C2, C3 going into the trigeminal all affect cranial vessel tone. So we treat, C1, C2, C3, T1, T2, and then anything that feeds into trigeminal, and which are really many things in the cranium, including dura, would all feed into the migraine world. So headaches are a multi-course, paradigm. You really have to have quite an arsenal of techniques to really consistently treat headaches. Although I have to say the most common type of headaches that are not being managed well in medicine are not the arterial-based headaches, which can respond to many of the medications. They are the venous pressure headaches. Okay, so when you get that lymphatic system pressure that is driven up and the cranium is not draining, like post-concussion syndrome, and venous headaches, they do not respond to the meds very well at all. And that's because, the sympathetics have a different impact onto arteries and veins than they do into the lymphatic system. So a large percentage of chronic headaches are dural and vascular on the venous drainage side.
And with counterstrain, can you have an effect on bones?
Yes, that's why I threw that particular picture in there for you guys to show the bone marrow edema, localized demineralization. So like if you look at someone's x-ray who had an old back injury, you'll often see that at those segments, you can see some focal degeneration, osteoarthritis. And what happens is through that same reflex that I described, you get sympathetic activation into the segmental arteries, which feed the bone. Okay, so what you get is vasoconstriction into the bone, and you can get bone marrow edema. It can become painful. But that vasoconstriction driven by that loop I described is artery constriction and vein. So you get swollen, but poor perfusion, poor feed. So over time, you have this inflamed and degenerating joint. Okay, same thing happens with your knee. You get this old sprained knee when you played football when you were 16 years old. People stretched it out a little bit, if you had any rehab at all, but they didn't fix the chronic vasospasm in your knee. So, 35, 40 years later, that's the knee that becomes degenerative because there was sympathetic drive and you had poor perfusion into the bone.
Okay, thank you. Then we have a question about what's the difference between craniosacral therapy and counterstrain therapy?
So craniosacral therapy is a very older version of cranial technique for the cranium. It predominantly affects the dura and the cranial lymphatics. Okay, so it is something that does feed into the drainage pathway. If I have someone come to me and I as I said, as you read in my bio, most of my patients, fly in or drive in from out of state. They've seen many people, and I take that group of patients. And if they've seen a craniosacral therapist, they typically, their dura moves pretty well, and their cranial drainage is pretty good, but the cranial bone, the cranial nerves, the arterial pathways, the neuron pathways will not be addressed. They also tend to miss a lot of neck stuff because it's really a cranial technique. So I would say it can be direct or indirect, and it mainly affects two systems, which is the dura and the venous drainage of the cranium.
Thank you for your answer. And then can you recapture a medially or laterally displaced disc in the jaw joint?
So complete dislocations don't counterstrain, very well. When you see, I would say where the wheelhouse is where you see this tracking issue, this misalignment. You'll see capsulitis. Obviously, anything that is more neural based. That's kind of our wheelhouse. When you get a fully dislocated or displaced disc, those are also often cases where we get the dentist involved.
And then what's your take on tinnitus and its treatment?
Yeah, if you ever hear I committed suicide, it was from tinnitus. I shot myself. Yeah, from not being able to fix it consistently. So I've looked at that over the years, and anybody who has treated it knows that you have the cases where you'll find dysfunction of the TMJ locally, or you'll find some areas in the mastoid and upper cervical spine. but there is this constant bilateral version that really doesn't have anything to do with the TMJ. And what you'll see, because again, I'm now mapping all the structures into the brain and brainstem, it is really that entire pathway in the posterior brainstem that goes up into the thalamus and the area of the inferior colliculus and medial thalamus, and of course the vestibular cochlear nerve. So there's a neural inflammatory pathway in the brainstem, and the more skilled I get at working in this area of the brain, my success in chronic tinnitus is starting to go up quite a bit. But the idea that you can treat it all through the jaw and that it's simply an upper cervical thing, it exists, but there are many cases where that will not work.
Well, thank you for your answers, Dr. Tuckey. I think this was a wonderful presentation, and it's got everybody asking tons of questions. And so my experience with Counterstrain has been that I've been able to help a lot of my patients chairside who were coming in with headaches. And I always start by releasing some cranial sutures, and then I check the cranial scan to see what I can do to help them. And the courses that I've taken were just very educational. I learned so much from learning how to treat the body. I've treated family and friends, but in the professional settings, ideally, it would be nice to have, other than the techniques that I've learned, a physical therapist working with me in the office, ideally to be able to treat those patients so I can devote my time treating my other patients. These techniques are great. The introductory course is a great way to learn how to feel what a tender point is and how to release it. And then for dentists, I think that maybe taking the cranial course would be a good one after taking the lymphatic course. And this will be a good introduction to determining if dentist wants to delve into the world of Counterstrain. It's once you start learning, you just don't want to stop. This has been my experience.
Yeah, I think it's something that you kind of decide to do it and really go all in, as Dr. Frizzelli has, or you encourage somebody in your staff or a therapist that you know to do it. Taking the foundations class and understanding, and being able to assess it and understand what neuromuscular dysfunction looks like, I think is invaluable. The ideas of convergence, the ideas of this stasis, this entire nociceptive loop, what is driven by trapped inflammation in nociceptors. This is not stuff that you learn in school. And, a lot of the research, even the idea of convergence as to what a tender point is, that was first in the research in 1990 in animals. And, I did that Facebook Live, and, there was just people after people say, I just got out of school, I've never heard of that. There's so much that's taught in school that is such an old pain paradigm. So yeah, I at least encourage you to read the article. I think you'll find that when you start understanding that the vasoconstriction is part of this pain loop, the muscle guarding is part of this pain loop, things will make much more sense to you. And then you realize that pain receptors are in all tissues, not just the musculoskeletal tissues, and that you don't have to force things for it to work. Okay, it's the indirect world is actually way more powerful. So the whole thing is again kind of an update in the modern tissue science and treatments, and unfortunately, like I said, schools are kind of slow to pick up on that.
And we have one more question, Dr. Tuckey. Will tight lingual or labial frenum interfere with Counterstrain therapy?
Generally, no. Yeah, there aren't too many things you can't Counterstrain around, if that's the question.
Yes. Everything is permeated by fascia, and fascia is what we treat, so we can treat everything.
Yeah, if it has a nerve, and a vasculature supply, like a new class I'm bringing out this year is the adipose system, because it is vascular, it's neural, it's part of the fascial continuum, and it is also has innervation of sympathetic and somatic nerves of that level. So it's a pain generator. So there are entire systems that you would never think to treat. Fat pads, for example. There's epidural fat in each nerve root. All the white adipose tissue, the surface adipose tissue, subcutaneous. It's the world of pain and dysfunction is very, very large.
And I'm looking forward to this class next week. We have quite another question. How do we find online your graduates and where to refer to counterstrain specialists?
Yeah, great question. That's the counterstrain.com. This has a practitioner search feature. And to get onto counterstrain.com, you had to take at least 4 classes. Okay, so it doesn't mean they're necessarily an expert, but I do instruct my students to, if you get a patient that again you feel is out of your area of expertise, they're just too complex for you, you treat what you know and then you refer them on to someone or recommend they go. So we really don't try and treat people beyond a certain point. If we can't make a big change or send them to somebody who can, we're not going to just treat them over and over again. It's not the paradigm.
Excellent. And then we have a comment from one of our attendees. It says, absolutely amazing lecture addressing the root causes of problems. And I would love to be treated by you. So how busy are you, Dr. Tuckey?
Pretty busy. Yeah. I take patients by email that request to be seen. And I to be honest, I've been focusing on patients that have, basically head injuries and severe chronic pain so I can map out those pathways. Having said that, practitioners, doctors or anyone who wants to experience the work, I do take them. But if someone sends me a sprained ankle, I know how that goes. I don't take sprained ankles. Nothing I know how to fix do I take anymore. I'm about, I think I'm about 4 months out booking.
Wow. Well, thank you very much, Dr. Tuckey. That was awesome.
Yeah, well, thank you, Dr. Fursley, for the ability to talk to everyone. Again, I think in general, the paradigm is something that everyone would find valuable, even if they don't train in it. Understanding tissue science, pain science, and really what the article does, and again, I really hope you guys read it, is it combines the world of pain science with lymphatics. And that was something that was never done before. Okay. And the answer to chronic pain turned out to be hooked into the lymphatic system and the drainage system. And if you look at the research, the people who publish on lymphatics know very little about pain science, and the guys that know about the pain science knew very little about lymphatics. And being someone who works in both worlds and teaches classes in both, I realized that was the unique view that I had, and those other doctors were pretty unaware of the entire role of the lymphatic system, even those world-renowned pain guys. So anyway, that's where the two systems are interacting. And I think that's why so many people have chronic pain.
Excellent. Well, there will always be a need for people who treat chronic pain in this world.
Yes. I don't think it's going anywhere, right? It's job security.
Okay.
All right.
Well,
Well,
thank you so much.
thank you again. And thank you to anyone again. If somebody does want to experience the work, under counterstrain.com, you can find someone local. My clinic is, if you look up under counterstrain.com, my face comes up first under the practitioner search. I have very high level people at my clinic. They're all fully certified. So you could even come and get a treatment from one of my staff members well before 4 months if you want one.
Excellent. Thank you everyone for your attending tonight, and have a good night.
Thanks, everyone.
Thank you.